more responsibility for their health.
Our patients will be different in the future. By our vision date, 2020, 1 in 5 will be older than 65. And for this group, the baby boomers, living longer is not going to be enough. They want to live better. They're going to be more aware of health and wellness, and they're going to have the money to pay for it. They're going to be more discriminating when it comes to the selection of their health care providers and the treatment they're going to accept. They're going to self-educate through the internet. They're going to be more interested in prevention, cosmetics, comfort, more concerned with the value of treatment. And as our world moves from a handshake to a keystroke, our patients are increasingly becoming informed consumers with an increasing responsibility to select from a wide array of choices.
Now, those people who observe future trends use a term megatrend to describe the seismic type of shifts that influence changes, multiple changes throughout society. And the consumer megatrends that have been identified for the future have several that appear to likely influence our profession. Among the most prominent are the patient's and the consumer's desire to prolong a healthy, active life. Our patients do not expect to be considered old at age 70. And this links up with great frustration that exists today in terms of the delivery of medical care and the whole healthcare delivery system. Consumers are more self-reliant today in terms of health care because they do want to remain healthy longer. And one of the factors that is feeding in and fulfilling the needs that consumers are demanding is an emphasis on nutrition. Now, not the nutrition that many of us have seen the last few years, where you can't tell what's going on the shelf in terms of vitamins and a variety of herbals. But we're talking about a whole different level of nutrition. The major nutrition and food companies today are investing very heavily in products that will have true, proven value and health benefits. And most importantly, the FDA has explicitly and publicly declared that they will establish regulatory guidelines to assist those companies in developing these products and to assist the consumer in differentiating between true, valuable nutritional products and garbage that may be out there. And inflammation is one of the primary targets for these large investments. There are today large randomized controlled clinical trials on nutritional products to reduce chronic inflammatory diseases. In addition, did you know that one of the leading dental insurance companies today has invested and is developing nutritional products for the prevention of caries and periodontal disease?
Well, I don't know about everybody in the audience, but even standing here in the year 2003, I find it hard to believe there's food out there that's going to be delivering drugs. But I tell you what, Jay Siebert, Drs. Hall and Goldman and Hine, when they were asked to write in the Journal of Periodontology in 1973 about how they felt the practice would be like in the year 2000, Jay Siebert must have really had his crystal ball all polished up. I mean, look at Jay's words. For those who miss the administration of preventative chemotherapeutic agents in mouthwashes, communal water supplies, and foodstuffs. I mean, Ken and I were in dental school when this publication came out. We certainly couldn't envision the future, but we did know that implants didn't work and that you couldn't cover roots with grafts. Things, I guess, have changed.
And all of this interest in a prolonged youthfulness is going to increase the importance and the desire for aesthetics. In addition the self-reliance and self-determination of health by our patients and all the consumers out there is really bringing an increased interest in this message that we're conveying, the shocking message that for some reason the mouth is connected to the rest of the body. So we've had phenomenal response to the stories about periodontal disease association with cardiovascular disease and a variety of other systemic disorders. And it's very likely that those associations and those messages are going to continue to reverberate through the population. For example, during the somewhat contentious ethical and political debates about the role of stem cell research and fetal tissues, there was general agreement that these stem cells have the potential to produce tremendous advances in areas that are today very frustrating, with neurodegenerative diseases and spinal cord injuries. Just a few months ago, investigators at the NIH reported that exfoliated deciduous teeth actually have stem cells that can be isolated, and from those stem cells, you can grow bone and you can grow nerves. Now, as a parent, this is an interesting dilemma. I can imagine an entrepreneurial 6-year-old no longer thrilled with taking a $2 deal from the tooth fairy when the stem cell bank down the road is offering $100 per baby tooth. Now, let me ask you for a minute to think about what this really means. What we're really talking about is an unconscious emphasis throughout the population of the importance of the oral cavity, the opportunities of keeping your mouth healthy, and the whole implications relative to the boundaries of this profession and how we're viewed by the outside world. Most importantly, we have the opportunity to lead, and patients will expect us to do so. Now, with those new expectations from our patients, there are new technologies available now that will change our capabilities and change the services that we provide.
And as periodontists, some of them are threatening because they're telling us two things. They're telling us, number one, there'll be fewer patients coming to our office with periodontitis, and there's going to be less and less need for mechanical therapy on those patients. Drugs, both local and systemic, will magnify the effects of root plane and scaling, perhaps even prevent the need for root plane and scaling through host modulation, control of inflammatory mediators, and stabilizing attachment loss. Just because clinical research in these areas have been less than impressive in the past, don't think we couldn't have breakthroughs in the future. All of us need to be careful about the trap of the first versions. Just because the first version of a product or a technology is not impressive, don't switch off your radar screen. Instead, you need to apply the silver bullet test. Look at a new product, a new technology, and say, if it were 10 times better than it is today, and if you're still not interested, then life's going to go on, but just with another gadget. But if you look at that technology or that product, and if it were 10 times better than it is today, and you were to find it threatening or you were to find it exciting, you may be looking at disruptive technology. We need to discipline ourselves to separate the quality of the first version from the long-term significance and impact of new technologies.
And among those new technologies, of course, will be the development of some new drugs. And the intriguing thing is that some of these drugs will be developed for totally unrelated uses and will inadvertently be treating our disease. So we could start by asking who will be treating periodontitis in the year 2010 and 2020, but the real question is, who's treating periodontitis today that we don't even realize? Bisphosphonates, Fosamax, used by hundreds of thousands of women for osteoporosis. We know that that drug halts the progression of periodontitis, and Merck knows that also. Statins, taken by over 44 million people around the world to lower cholesterol. In recent years, it's become clear that statins have an unusual ability to totally change, in an anabolic way, bone remodeling to make bones grow. And in fact, postmenopausal women who are taking statins for cholesterol purposes have significantly more bone density and fewer fractures. So let's imagine for the moment that all 44 million individuals on statins have a reduction in their periodontal disease progression by 0.2 of a millimeter per year. How would this impact on our practice and on our profession? Secondly, there will be some drugs developed intentionally and marketed for periodontal disease. If you look at the list of all the drugs being developed today in the pipeline, the two major areas are oncology and inflammation. And although the periodontal marketplace has not been real exciting in the past from a market potential in terms of drugs, and really has never fulfilled its potential, it's very different if the drug has been developed for a totally different use. The major cost, of course, of drug development is getting that first indication approved by the FDA. And so if it's for arthritis or for some other inflammatory condition, but you can then develop a secondary or tertiary market, that's gravy. It's very likely, with all of these drugs being developed for inflammation, periodontal disease will be an interesting secondary or tertiary marketplace. And of course, there will be a variety of new technologies, things that already exist in some form, that will impact dramatically on what we do.
And this, of course, is the positive side of technology. Technology should broaden our scope of practice. It should allow us to do things that we can't do today. Tissue engineering, biomimetics will usher us into an entire new generation of repair and regeneration. Bioactive implants are just around the corner. We're going to be able to place them where we can't now and load them earlier. We're going to have access to a more sophisticated armamentarium. Robotics are going to help us place implants. Lasers will assist us in more precise surgery. Nanotechnology and proteomics will revolutionize what we do. All of this will result in more treatment options for our patients, more predictability, but all this is going to be a lot more expensive, and it's very unlikely that much of any of it's going to be covered by third parties.
So what if in the future, physicians and dentists could predict with some reasonable accuracy what diseases you're most likely to get over the next 10 to 20 years, and could identify what drugs are best for you that may be different from what's best for the total population, and can assist you in avoiding complications from some of these drugs. Well, this, of course, is the promise of the Human Genome Project. And out of the 3 billion letters that make up the recipes for life in the human genome, we differ among ourselves at very few of those places. And it's those same tiny variations that appear to determine, to a great extent, which of us are going to live comfortable, active lives into our 80s and 90s, and which are more likely to have complications of chronic disease in the 50s and 60s. Many of us in this room know the story of Jim Fixx quite well. Although he smoked at certain stages of his life, he became a proponent for healthy lifestyle and was a world-renowned marathon runner, and died at age 52 while running. Of course, his father died of an MI at 43. And we contrast this with Winston Churchill, a legendary glutton, lived until 90. We know today that if a woman carries a genetic factor called BRCA1, she's 7 times more likely in her lifetime to have breast cancer. And if she gets breast cancer, it will probably occur earlier and be more aggressive. We know that some of you in this room carry what's called a delta 508 deletion. It means you're missing 3 of those 3 billion letters at a specific place, and you're more likely to have a child with cystic fibrosis. We know that one single variation among those 3 billion in a specific location increases your risk for a first heart attack in your 50s and 60s 4-fold, even if you have normal cholesterol. And we know that 2 of those letters in the 3 billion, if you change them, increase the risk of severe periodontal disease. Now, even if the application of this information does not happen immediately, your patients and all consumers are being told that this is better medicine, and they should expect it. Today, some forms of cancer are being diagnosed and treated based on very specific genetic differences. And those applications, which are expanding dramatically and will do so in the next 5 years, are very likely to produce dramatic changes in the outcomes of certain cancer therapies. It's very likely that the medicine we have today will be considered primitive to our grandchildren. And it would not be surprising for some of you to receive a question, "Grandpa, are you pulling my leg? Did people really give patients poison and cut off their body parts to try to cure cancer?" And why shouldn't we have a better toothpaste? One that actually prevents plaque formation, plaque growth interproximally, and really does something for the periodontal health in a very dramatic way for our patients. There are several biotech companies with extensive technology and investments on controlling biofilms, primarily for purposes of beer making and cardiovascular disease. But on all of their websites, they mention dental plaque control as one of the important applications of their intellectual property. We know this is not a dream. We know, although there were complications in the practical use, chlorhexidine demonstrated to us years ago that it truly was practical on a clinical level to rinse your mouth out twice a day or brush your teeth once or twice a day with this compound and prevent plaque, prevent gingivitis, and prevent periodontitis. There are many possibilities. Let's imagine for a moment that just one of these possibilities comes to fruition in the next 10 years. And let me read just one paragraph from the front page of USA Today, September 21, 2013. 2 studies showing that treatment of gum disease reduces both first and second heart attacks almost as much as the widely used cholesterol-lowering drugs will be published in this week's Journal of the American Medical Association in a joint press conference convened by the National Institutes of Health and the American Academy of Periodontology Foundation. Researchers discuss the practical significance of new findings from large studies funded by these 2 groups.
And of course, what that would mean is lots more referrals to us with patients who have periodontitis and systemic considerations. It would also mean that medical protocols would now contain evaluation and treatment for periodontitis. But evaluation and treatment by whom? We'd find more collaboration with physicians on patient care, on research, But more collaboration also means more head-to-head competition with the oral surgeon as to who is going to be the source of dental knowledge in the medical world, and more competition with physicians themselves as they begin to treat some forms of periodontitis. So while there really are no facts about the future, the evidence is abundantly clear. The way it was is not the way it is, and the way it is not the way it will be. Our patients are changing, community attitudes are changing, and technology, all of this is changing